Do you foresee combination therapy for multiple myeloma changing in the next few years? And how would this impact the treatment paradigm and potentially guideline directed care?
Uh, Excellent question. And if I understand your question properly, combination therapy with CAR-T or combination therapy for newly diagnosed patients?
Both scenarios, if you could speak to that.
Yeah, so I think let's talk about patients with newly diagnosed multiple myeloma. So right now, we know that for majority of the country, the standard of care is a combination of three different medication. May it be bortezomib or kyprolis, those are the proteasome inhibitors, Revlimid or lenalidomide, and dexamethasone. Now, there is a huge debate nationally about does or internationally, I would say, adding a fourth agent improves things. Now, there are questions about improving response and the durability of response. So can you get the response first, and can you sustain that response? Those are two different questions. Now, we know most of the therapies as of today, including the triplet therapies, are able to get a response. It's the durability is an issue, and can they persist for a longer time, or getting the patients into minimal residual disease or the lowest disease possible. Some call it measurable residual disease, some call it minimal residual disease. So the point it comes up to, are we going to a quadruplet therapy? And the answer to that is yes. I think we are going to a quadruplet therapy, but for who is going to be a point, for how long, and when do you increase the intensity of therapy, when do you decrease the intensity of therapy? Would MRD be a guide to deciding how those therapies are done, are going to be some of the crucial factors in deciding. So I don't think quadruplet is needed for every single individual with newly diagnosed myeloma. There are subsets who will benefit from it, and there are subsets who probably do not need that aggressive treatment.
Okay. And speaking to the combination of CAR T cells,
Yeah, yeah. So I think that's probably a more challenging question to say. So that do we, from two different ways, right? I mean, first question is scientifically that should we combine something to CAR T cell therapy to improve its response? Now, as I mentioned earlier, that CAR T cell therapies and lymphoma has shown certainly a more impressive responses than what we might have expected in myeloma. Having said that, the diseases are completely different. The biology is completely different. So we certainly don't want to compare apples and oranges here. But obviously, there is a challenge in front of us that how are we going to have these CAR T cells persist to be effective for a longer period of time? So obviously, there has been an ongoing debate and also a lot of clinical trials ongoing which are thinking of adding medications to the CAR T cell therapy treatment, and that may be medications like immunomodulatory drugs or proteasome inhibitors. I mean, Image or Revlimid or Pomalyst, I mean, those are certainly a key targets here to think of. Even checkpoint inhibitors have been used, like in some clinical trials, like PD-1 or PD-L1 inhibitors in some clinical trials. So I think those are another avenue of interest. And I think the more important question to me is what combination to use rather than what are the potential mechanisms of relapse. Like, why is CAR T not working for individual A compared to B compared to C? Is it because the cells are not persisting? Is it because they are losing the BCM expression? Is it because the CAR Ts are not expanding at all? And the intervention for each bucket is potentially going to be a different intervention. And so some might need a BCMA targeted ongoing therapy after CAR T cell therapy. That might be a strategy in one population versus other might need just augmentation with an IMiD. And maybe there is a third who does not need any intervention at all. So I think scientifically speaking, as a physician and a physician scientist, I would think an important thing for us to understand is what are these different categories of patients where we would intervene differently and appropriately. Now, if I had to put my hat of talking to my patient as a physician, as clinician, sitting in the patient's room and thinking of the challenges in the healthcare system, I mean, we loved CAR T cell therapy that we don't have to combine with anything, right? I mean, the initial 2 years, we loved it that you get CAR T cell therapy. My patients feel, they tell me that, hey, doc, I feel like I don't have myeloma at all. That's the comment I get very often from my patients who have received CAR T cell therapy. So, a majority of these guys have got stem cell transplant before and have been on maintenance therapies and some ongoing treatment. So when it comes to us doing some combination along with CAR T cell therapy, that is certainly a bummer from them saying that, hey, like, this was kind of one of those hope where we would have done one time thing and it would work forever. And so I think as from the patient's perspective, as a healthcare cost perspective, as a physician sitting in front of them and trying to think what is the easiest on in their patient reported outcome standpoint, I'm not too excited about combining things, but I suppose it is going towards that way to get the best efficacy. So I think rather than saying everybody should get a maintenance therapy like we do for transplant for a big chunk of our patients or pretty much everybody in United States, I think we will have to think of a much more scientifically driven answer that who benefits from it.